Hey guys, this is Caesar with Nursing School Made Easy, and this lecture is going to focus on hypothyroidism. I'm going to try to simplify this as much as possible because sometimes with all of the hormones, things can get a little bit confusing. So again, I'm going to try to just oversimplify things. So let's jump right into it. And let's talk about a little bit of anatomy and a little bit of a physiology, just to review things in case you're needing a little bit of review. So this is going to be my awesome picture of a head, and it's going to be the throat. And on your throat, on your trachea more specifically, you have a little gland. Now again, I'm oversimplifying things and I'm over exaggerating on my drawing here. So on your trachea, you have a thyroid gland, and no, it is not this big, but again, just to make it easier to visualize on camera here, you have your thyroid gland. Sits on your trachea. Now, you also have something else called the pituitary gland, and that is in your brain. Now, the pituitary gland secretes thyroid-stimulating hormone. And just like the name implies, thyroid-stimulating hormone, TSH is going to come here and stimulate your thyroid gland to secrete T3 and to secrete T4. Okay. Now the pituitary gland is also stimulated by something else called the hypothalamus. And the hypothalamus secretes TRH. TRH excuse me, stands for thyroid releasing hormone. So TRH is going to tell your pituitary gland to secrete TSH. And that is what we want to focus on. We want to focus on TSH, T3, and T4. Okay. So if you remember anything from this lecture, remember that your pituitary gland is going to be stimulated to produce thyroid-stimulating hormone, which is going to stimulate your thyroid to produce T3 and T4, because these will be the thyroid hormones that we will focus on. Because in hypothyroidism, there will be very, very little or no production of thyroid hormones, hence the name hypothyroidism. So it is a decrease in thyroid hormone secretion. Yep, misspelling there. So again, decrease in thyroid hormone, and that is our T3 and T4. Now, in a different lecture, we talked about hyperthyroidism. Just hyper. That was in a different lecture. And in hyperthyroidism, people suffer from a very, very intense or very, very hyper state. So you're running around all the time, you're sweating all the time, you have something called heat intolerance. You're just constantly moving, you're pacing back and forth, and because you're pacing back and forth, you're moving around, you're running around, you're eating a lot of food. Well, you're eating a lot of food because you're burning a lot of energy. And since you're burning a lot of energy, you're constantly moving, you're producing a lot of heat. Well, in hypothyroidism, again, hypo, you have the opposite of that. You have somebody who is very, very, very tired all the time, somebody who's weak, somebody who isn't exerting any energy. They're extremely somnolent, they're extremely sleepy. Well, the reason they're extremely sleepy, somnolent, fatigued is because there is no thyroid hormone. There is no T3 or T4. Okay? Those are just a little bit of the clinical manifestations or signs and symptoms. Well, let's talk about the causes first. What are some of the causes of hypothyroidism? Number one, now in hyperthyroidism, we talked about something like Graves' disease, something like Hashimoto's thyroiditis. And in Hashimoto's thyroiditis and in Graves' disease, we had a ton of T3 and T4 being produced. Again, hyper. Okay? So you're having a ton of T3 and T4. Well, if that thyroiditis, if that inflammation continues to occur for a prolonged period of time, what will end up happening is the thyroid gland will actually be destroyed. Now, we talked about how sometimes it can be an autoimmune disease, meaning your own body attacks your own immune system attacks your own body. And in this case, we talked about how the thyroid gland may be destroyed. Well, if the thyroid gland is destroyed, you cannot produce T3 and T4. So again, one of our causes could be something like Graves' disease or Hashimoto's thyroiditis. Yes, Graves' disease or Hashimoto's thyroiditis. So those could be some causes. Now, we also talked about if you have some type of thyroid pathology present, something like a thyroidectomy will be performed. And if a thyroidectomy is performed, well, then they come in and they may remove part of your thyroid gland, or they may remove the entire part. Well, if you have no thyroid gland, again, you cannot produce T3 or T4. So that would be cause number 2. Now, sometimes surgery may not be performed, but maybe some type of radiation therapy may be done. Again, the radiation therapy will come in and have an effect on the thyroid gland. And again, that type of therapy may destroy part of it or the entire portion of the thyroid gland. Again, if the thyroid gland is destroyed, you have no T3, you have no T4. Another cause for it would be something like iodine deficiency. Number 5, medications. Now, there are 2 medications that I want you to focus on, that I want you to know, that I want you to memorize for your NCLEX. Number 1 is amiodarone. And number 2, lithium. These 2 medications can cause hypothyroidism. So make sure you know these for the NCLEX. Now, let's talk about some signs and symptoms that your patient may show. Excuse me. Number 1, in the very beginning of the lecture, we talked about hypothyroidism, how you're going to have a slowing down of all your processes. You're going to be weak. You're going to be tired all the time. So let's jump in to our clinical manifestations or signs and symptoms. Number 1, fatigue. These patients are always going to be tired, going to be lethargic. Number 3, extremely sleepy, extremely somnolent, or somnolence. They're going to be drowsy, they're going to be fatigued, they're going to be lethargic, sleepy. They're going to also have change in their mental status or altered mental status. They're going to have problems with memory. They're going to have slow speech. Now, a very important thing to remember is in hypothyroidism, the heart is actually going to begin to pump slower. In hyper, boom, 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 boom. Heart's pumping very, very fast. In hypo, again, decreased cardiac contractility. And because of this, you're going to have decreased cardiac output. Now again, every system in your body requires oxygen. If your brain is not getting the oxygen that it needs due to decreased cardiac output, that will have an effect on your mental status. So this altered mental status, now we see why we have that. And then we see why we have a change in their memory. This is very important that you know. Decreased cardiac contractility will result in decreased cardiac output. Now again, if the lungs are not getting the blood supply that it needs, you will suffer from shortness of breath, shortness of air. If your muscles aren't getting the oxygen that it needs, you have some weakness. Again, fatigue. The lab values will actually show decreased hematocrit. Now another body part that will affect it will be your GI tract. You'll have decreased GI motility. Simply means decreased bowel sounds or hypoactive bowel sounds. Now because your small and large intestine aren't moving like they should, they're not moving those stomach contents through your body, you have a very high likelihood of becoming constipated. So again, you want to assess those bowel sounds. Are they hypoactive? If so, this patient again runs a high likelihood of becoming constipated. A big one that you want to know is these patients are very, very prone to cold intolerance. So you always want to assess their temperature. You want to make sure that they do not become hypothermic. Okay? These will also suffer from hair loss, coarse skin, brittle nails. Make sure you know these for the NCLEX. Cold intolerance, hair loss, coarse skin, brittle nails, because you may get a select all. Swelling and weight gain. Now another thing that you may see on the NCLEX is something called myxedema. Now this is specific to hypothyroidism. Now this is a medical emergency because something called a myxedema coma can result. Okay, so here you want to assess the patient. Do they have facial swelling? Do they have puffy eyes? Something called periorbital swelling. Now, anytime you have swelling of the face, you always have to worry about the lips, the tongue becoming swollen, because if the face gets swollen, if the mouth gets swollen, you always run the risk of your nasal oral region becoming so swollen that you cannot breathe in. And that does have an effect, because if you're not breathing in any oxygen, that is going to affect your brain, your heart, your entire body. Okay? So you always want to assess for this myxedema. Now let's focus on some diagnostic studies. A lot of the diagnosis will occur on the signs and symptoms, but the two things that you want to focus on in the NCLEX are one, TSH levels, and number two, free T4 levels. Okay, so these are going to be lab values that you want to look at. You want to make sure that you, again, know these very, very well. Very, very well for the NCLEX. Again, your TSH levels and your free T4 levels. Now, why? Why are these important? Okay. Earlier we talked about how in your brain you have your pituitary gland. Okay, your trachea, thyroid gland. We talked about how your pituitary gland is going to secrete TSH, thyroid-stimulating hormone, right? Now your thyroid-stimulating hormone is going to come down here to your thyroid gland, and it is going to stimulate it. It's going to tell it, hey buddy, start working. Your thyroid gland will then produce T3 and T4. Now this is in a perfect world, but let's say your pituitary gland is not working. So the doctor's going to say, well, what are the TSH levels? Let's get some blood, let's draw some blood, and let's check out those levels. So somebody's going to come in and draw blood, and they're going to look again for TSH. And they're going to ask the question, is it the pituitary gland that isn't working, or is it the thyroid gland that isn't working? Well, if you have no TSH present, that will let the doctor know that it's most likely the pituitary gland that is not working. Because again, if the pituitary gland is not producing TSH, then the thyroid gland will not produce T3 or T4. Okay, so in that case, both of these levels will be down, will be decreased. But there is another scenario. Maybe your pituitary gland is working, and your pituitary gland is secreting TSH, and your thyroid gland is not working. Well, how could we determine that? Well, in that scenario, your pituitary gland again is going to secrete TSH. TSH is going to come down here. Now let's say that this patient had some type of autoimmune disease, and now the thyroid gland has become destroyed, and it is no longer functional. If it is no longer functional, thyroid secreting hormone will come down and will try to stimulate the thyroid gland, but if the thyroid gland isn't working, no T3 and no T4 will be produced. As a result, your pituitary gland will try to produce more TSH. Okay? And I'm going to use the cell phone analogy. You're texting your buddy, hey, pick up your phone. You get no response. So you text him again, hey, pick up the phone. You get no response. Hey, pick up the phone. You keep texting and texting and texting and texting and texting and texting. Okay, so you're texting a lot. But the other person's phone may not be working, or their service may be out. So it doesn't matter how much you text, they're not going to get the message. And this is like that, okay? Because in this scenario, your pituitary gland is texting. So if you want to think about it as texting, the T and TSH is texting, your pituitary gland is going to keep texting your thyroid gland. It's going to keep sending message and message and message. So your thyroid-stimulating hormone is actually going to increase. So if they do some blood work, it's going to increase, right? Because again, your pituitary gland is going to keep sending a text. Hey, dude, wake up. Hey, come pick me up. But your thyroid gland, because it is destroyed, is not going to receive the message. So no T3, no T4 will be produced. So in that scenario, TSH or texting will go up. But again, because the thyroid gland is destroyed, isn't working, you will have no T3, no T4. You will have no thyroid hormone produced. So in that case, there will be no T4. So again, diagnostic tests would be doing some lab work and testing for TSH and T4 levels. Now, what are some interventions that you would do for these patients? Number one, we talked about how these are going to have some weight gain. They're not going to be moving at all. They're going to be very fatigued. So anything that they eat, all that weight, they're going to accumulate. So you're going to want to change their diet. You're going to put them on a low-calorie diet. Number two, the most important thing you can do is you can actually give them some thyroid hormone. So you're going to give them some levothyroxine. Make sure you know this for the nclex. Levothyroxine or Synthroid. Okay. If it is an emergent case, it can be IV. You don't want to waste time, especially if they're suffering from myxedema coma. Now, think of levothyroxine as a big drink of caffeine, big jug of coffee. One of those energy drinks. In the very beginning, we talked about how these patients are just weak, tired all the time, how their heart isn't pumping like it should. It's very slow. So they're having decreased cardiac contractility. Along with that decreased cardiac contractility, they're having decreased cardiac output. As soon as you give them some levothyroxine, it's going to wake up that heart. It's going to boom, 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 boom. Okay? It's going to stimulate the heart. Hey, buddy, wake up. Come on, man. We got to work. We got stuff to do. We got to study for the nclex. So that heart's going to start pumping faster. It's going to start delivering more blood to the brain. It's going to start waking that patient up. It's going to start getting those muscles excited to go do some work, go do some studying. Well, in a normal patient and a healthy patient, that's really not a problem. But if a patient has cardiac issues or cardiac history, if you went from a resting state to all of a sudden bam, 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 heavy pumping, you run the risk of causing a stroke or cardiac problems. So with these patients, you always want to ask, you always want to assess for chest pain. Ask them, is your chest starting to hurt? Are you having any mediastinal pain? Because if so, you always want to make sure that they aren't starting to have a heart attack. So you will also get an EKG if chest pain does occur. Okay, so these are very important things to do when you give levothyroxine if it is the first time. Assess for cardiac issues. If so, make sure you ask if they're having any chest pain. You assess that patient. If so, you get an EKG. You put them on telemetry. Okay? You also want to inform your patient that this is most likely a lifelong therapy. They will have to take this every single day. Now you also want to make sure that you assess their TSH levels on a regular basis, typically about every 4 to 6 weeks. Yes, it's very important that you give them their medication, but you also want to make sure that the medication is having the desired effect, so you do want to assess, monitor those levels. You also, excuse me, want to monitor their temperature. Because again, one of the things that we talked about earlier is how these patients run the risk of suffering from cold intolerance, okay? So you always want to assess their temperature. Make sure that they are not becoming extremely hypothermic. And the other thing that you want to assess for is that myxedema, that swelling, that facial swelling. You want to assess their mental status, and you want to report any mental status changes, any personality changes, any difficulty with breathing to the physician immediately. And I forgot to mention this earlier, but another medication that you may see on the nclex is something called Leotrix. and that pretty much has the same effect as levothyroxine. But in case you see that on the NCLEX exam, it is for patients suffering from hypothyroidism.